Good morning, Boone and Trish. I have a question for you both. What does clinically extremely vulnerable mean? And does it apply to the patients that traditionally come to see us, so patients with vasovagal syncope or POTS? And is there advice that we should be giving people about the vaccine? And this is obviously all in relation to the recent advice from the government about the shielding list of people that should be very careful about not even leaving their house because of the risk of contracting COVID.
So I think it's a great question. Having spoken to Trish, I think, who runs the tilt table service at Hammersmith Hospital, I've seen quite a few patients now with her who have had a significant worsening of their symptoms, which could be considered very POTS-like or very much in relation to orthostatic tachycardia. And importantly, a recent survey of over 3,500 patients had shown that a significant proportion of patients do describe long-standing COVID symptoms or long haulers COVID symptoms in the context of symptoms of dysautonomia. So so another way of saying that is if you're going to get long haul COVID or long-standing long COVID, a lot of your symptoms are predominantly going to be driven by dysautonomia. So coming back to the question, which is, should patients with syncope and POTS as a pre-existing condition be shielded? We don't actually have the data now, right now, to give us that information. But from our experience, the patients who are going to get more vulnerable or susceptible to dysautonomia type symptoms, which explains the whole constellation of multifaceted things after COVID, the so-called long COVID symptoms, are going to be the patients who pre-existing had low blood pressure states, had a tendency to POTS anyway. And so this forms a new category. Now, the shielding list refers to very specific diagnosis, such as patients with specific cancers or organ transplant recipients. But there is a very nebulous category where the description, and I'm going to read the phrase now, it says, other people who have also been classed as clinically vulnerable based on clinical judgment and an assessment of their needs. So what does this mean? This means that we can potentially, as clinicians, make an assessment on an individual case basis to recommend that a patient A is high risk and B, by virtue of that high risk nature, should be receiving a vaccine. So that would be my advice, that if you have a tendency to vasovagal syncope or a tendency to POTS or develop POTS-like symptoms during certain conditions or triggers, then it could be that getting COVID could trigger or worsen your POTS symptoms. And so I would then write a carefully worded letter to suggest that you should really take the ultimate and as many precautions as you can, which may include shielding, and which also may include having a vaccination. Trish, have you got any points to add?
Well, I'm just thinking in terms of some of the questions that come from patients would be, if, especially those patients, and we're not talking about the patients perhaps who've fainted twice in their lifetime, or just once and they've been investigated, but the patients perhaps who require medication to help support their blood pressure, they I think have questions as well about the potential interaction with vaccines, or whether that makes them somehow that they shouldn't have vaccines because of those medications. Do we know anything about that aspect of the susceptibility to vaccines and whether they should have them or not? Because I know that's a question that some patients do have.
So I think the short answer is we don't know. The long answer is if we look at the other spectrum, patients who are hypertensive or diabetic, who take long-term medications, but a different kind of medication to keep the blood pressure down, they are considered high risk and they should be offered and they should take the vaccine. So what we see in our group of patients with dysautonomia is a tendency to low normal blood pressures to start off with. And I guess it's always a balance. So in a patient who is pre-existing with low blood pressure states, to the extent that they need to take a blood pressure, then you could argue that their symptoms of syncope or POTS are actually greater than those who do not need to take a medication. Now, if that particular patient were to develop a full-blown COVID, i.e. a COVID infection, and be flawed for 3 weeks, the likelihood, in my opinion, and this is just opinion, it's not based on any hard data because none exist. My opinion is that the patient will have a greater than 50% likelihood of transitioning into a long hauler or long COVID type patient. Now, that is a subjective judgment based on experience, because as I say, there are no data. And the thing that you need to ask, or I need to try and answer now, is what is my thought process on that very same patient getting a vaccine and having the same reaction and developing long haul COVID after the vaccine. And my judgment is that that risk is less. So if you have the vaccine and you protect yourself from getting full-blown COVID that flaws you for 2 or 3 weeks, and then makes you set back in your clinical state with a greater than 50% chance of getting POTS-like symptoms, that vaccine that you have that gives you a 2-day period, just 2 days of feeling generally miserable, unwell with pain in the shoulder where your injection was given, that risk at that point is much less for you to then develop long haul. But there is a risk, potentially less than 10 or 15% is where I would guess that risk to be. So for the sake of taking a 15% risk of developing a less severe clinical form of long COVID, you are then protecting yourself with a greater than 90% certainty if you're given the 2 vaccines on time, and the vaccine profile is very good, you're given a 90% certainty of protection. So that question is very nuanced, Trish, and I've had to necessarily bring out some numbers, but not based on anything but clinical experience. Would you agree with that, Mel?
Yes. And I think the other thing to say is that, I mean, so far, so far we haven't actually, there haven't been a huge number of risks reported with the vaccine. And everything is always a risk-benefit kind of consideration. And the benefits of vaccination, as far as we know, far outweigh the risks as well. Which is why when people ask me whether they should get the vaccine, I encourage them to do so. So one final question, Boone, is if you're a patient sitting at home and you've got POTS or vasovagal syncope and you're not sure if you fall into that category, what should you do?
It's a difficult one because this is a data-free zone. So even if you were to look up any websites, whether a government website or the potsuk.org website, the nebulous guidance is as I stated, and I'll read it again. Other people who have also been classed as clinically extremely vulnerable based on clinical judgment and an assessment of their needs are people who should be considered shielding. And this is the shielding list, which then loosely translates into the vaccination list.
Yeah.
And the vaccination priority list.
And and just to summarize, shielding means obviously no contact with the outside world at all, doesn't it? Not even leaving your house and getting all of your prescriptions and shopping delivered to you.
Yes. So what should you do? It is very difficult because there are no guidance. I think you have to understand, maybe watch this short snippet again, what we've recorded, because ultimately the decision is between you and your caregiver. So you can't all come to see me or see the team here. You just have to make a clinical argument and advocate for yourself, and really in yourself deep down decide what it is you want, because there is no point going to see your GP and asking your GP to write a letter when deep down inside you don't want to have a vaccine. And equally, if you want to have the vaccine, you think it's a good thing after listening to what we've said today, despite the relative lack of data to support anything we've said, this is all clinical experience, then see your caregiver and make an argument, print out the guidance from the NICE on shielding, and print out the guidance from potsuk.org under the article Long COVID and POTS, and consider yourself and underline that final statement, which is clinically extremely vulnerable. Because obviously, if you then develop long haul COVID, you become fairly vulnerable and you might have debilitating symptoms for the next 6 months. And if that is a risk to you, then I think shielding or getting a vaccination is worth fighting for. So you have to be your best advocate.
Great. Thanks very much, Trish and Boone.
You're welcome.